Hello, everyone. My name is Vernon Maniago. I'm here to present my case presentation on the evaluation and management of a 26-year-old Hispanic male with urinary symptoms. On my patient, his chief complaint is one, he has dysuria, which is painful urination, and two, he has increase in urinary frequency and urgency, and he also has notable cloudy urine for a duration of about 3 days. The history of present illness. This is a 26-year-old Hispanic American male. His symptoms started about 3 days ago. He denies purulent drainage, but he does endorse cloudy urine with a notable smell. No other associated fever, chills, or flank pain, and no recent travel outside the United States. Looking at review of systems, generally he has no significant weight loss, fever, or night sweats. He has no chest pains or palpitations. He's breathing okay with no cough or shortness of breath. No issues with the abdomen, no nausea, vomiting, or pain. He does endorse the dysuria, increased frequency and urgency, and cloudy urine. No other joint pain or swelling, no headache or dizziness. Psychiatric history, he states history of post-traumatic stress disorder, currently stable with trauma-focused psychodynamic psychotherapy at the Department of the Veterans Affairs. Past medical history, he did mention a history of PTSD related to his military service, denies history of sexually transmitted infections, including HIV or other medical problems. Family health history includes paternal grandfather who has prostate cancer and coronary artery disease. His father has a history of hypertension, and mother has type 2 diabetes. Social history for our patient is military veteran, full-time student. He's sexually active with dating partners 3 in the past 4 months, but no tobacco or illicit drug use and occasional alcohol use. Medications and allergies. Medications none currently reported or currently prescribed. Allergies, he has no known drug allergies. Physical exam findings. Vital signs, he is 5'8" in height, weighs 162 pounds, blood pressure is 122/82, heart rate 72, respiratory rate 16, and A-febrile at 98.6. Generally, he appears well, no acute distress. He is alert and oriented times 4 with no focal deficits. HEENT is within normal limits, no scleral conjunctivitis, rhinorrhea, or ear drainage. There is no pharyngeal injection, no oral lesions, or lymphadenopathy. He has normal heart sounds, no murmurs appreciated. He has clear breath sounds, no wheezing or crackles. Abdomen is soft, non-tender, no masses, no CVA tenderness. No, he has no notable penile lesions or discharge noted. Testes are normal. And musculoskeletal, he has full range of motion with no notable tenderness or crepitus. Laboratory findings was performed in the clinic with a urinary dipstick. Results notable for leukocytes and nitrites for being positive. The urine did appear cloudy in appearance. There's no significant hematuria noted, and there are trace glucose but no ketones noted. Diagnoses. Here are potential differential diagnoses for our patient. May have a urinary tract infection. He may have prostatitis. He may have diabetes insipidus. He may have new onset diabetes or non-gonococcal urethritis, or NGU. But we were leaning towards a primary diagnosis of urinary tract infection and cystitis due to his current symptoms and his urine dipstick showing positive for leukocytes and nitrites. I'd like to delve into the epidemiology of the urinary tract infection for our patient. Urinary tract infections are highly prevalent in the United States, affecting 50 to 60% of women and about 12% of men, at least once in their lifetime. Women are particularly susceptible due to anatomical and physiological factors. The most common causative agents are gastrointestinal bacteria such as E. coli, Klebsiella pneumoniae, and Proteus mirabilis. Risk factors include female sex, recent sexual intercourse, diabetes, and structural or functional abnormalities of the urinary tract. UTIs represent a significant healthcare burden, accounting for millions of doctor visits and extensive antibiotic use annually. In addition, hospitalized patients with UTIs are associated with an attributed mortality rate of 2.3% and an estimated annual cost of 340 million to 450 million in the United States. Our treatment plan. Antibiotics choices. It is suggested first line for patients who are deemed to receive antibiotics therapy to either be prescribed trimethoprim, sulfamethoxazole, better known as Bactrim, or nitrofurantoin, better known as macrobid. It is also suggested for adult males with urinary tract infections should receive a 10 to 14 days course of antibiotics. Our patient treatment plan will include macrobid 100 milligrams orally twice a day for 10 days. We'll also include pyridium 200 milligrams orally twice a day for 3 days for his dysuria. We will also advise patient to increase his fluid intake and to follow up in 2 to 5 days if there's no improvement or if he experiences worsening symptoms such as a rising temperature or fever. We will also contact the patient if his urine culture shows a resistance to macrobid. Clinical Practice Guideline. This clinical practice guideline was referenced from the Infectious Diseases Society of America, or IDSA. In the treatment of uncomplicated UTI, with emphasis on antibiotic stewardship and appropriate selection. Macrobid at 100 milligrams twice daily for 5 days is an appropriate choice for empirical therapy due to minimal resistance and efficacy comparable to 3 days of Bactrim, and that is A1 evidence representing good recommendation and quality of evidence respectively. Bactrim at 160/800 milligrams twice daily for 3 days is an appropriate choice for therapy, given its efficacy as assessed in numerous clinical trials, and if the infecting strain is known to be susceptible, for example, from a urine culture, and that is with A1 evidence. Moreover, pregnant women should be screened for asymptomatic bacteriuria, or ASB, by urine culture at least once in early pregnancy and should be treated if the results are positive, and that is with A1 evidence as well. Looking at the algorithm from the 2010 IDSA guideline recommendation for women with an acute uncomplicated cystitis. If she presents with an absence of fever, flank pain, or other suspicion of pyelonephritis, then can one of the recommended antimicrobials be prescribed, such as macrobid or Bactrim? However, patient somehow it's not recommended, or patient is, for example, allergic to sulfa. And to the right, we may prescribe fluoroquinolones or beta-lactamase medications or antibiotics. Of course, the choice between different types of antibiotics should be individualized and based on patient allergy and compliance history, or local practice patterns, or local community resistant prevalence. And this is by Gupta et al. 2010. However, Reinich in 2019 suggested systematic treatment of ASB in non-pregnant women is not advised due to a higher risk of symptomatic UTI and antibiotic-resistant bacteria. Thus, it is important to perform literature review and stay up to date with the latest evidence-based recommendations to make a collaborative and informed decision with our patients. Patient education. We will educate our client on the importance of completing his antibiotic therapy course. We will educate him on the signs of urinary complications and recurrence. We will also stress safe sexual practices to prevent infections and potential health complications. More importantly, we will explain to him about other health problems he may be at risk for, such as diabetes and sexually transmitted infections and diseases. Follow-up plan. Again, just like patient education, follow-up plan is very important to also incorporate treatment guidelines, including updates. As you can see here, the 2021 STI treatment guidelines updates from the CDC. So we want to reevaluate the patient in 5 to 7 days. We want to repeat urinalysis if symptoms persist. We want to follow up the urine culture results and order pertinent labs if symptoms do not improve. We want to consider testing and treating for sexual transmitted infections due to his sexual risk factors. We also want to be screening the patient for diabetes if recurrent infections or other risk factors are present, such as his family history of type 2 diabetes. And that concludes my case presentation on our patient with urinary tract infection. Thank you so much for your time, and here are my references.